Hello viewers, good morning. I am Dr. Harinath, working as professor at SRM Dental College Ramapuram. Today we are going to see a video on a root coverage procedure where we have used laterally repositioned flap along with PRF for better clinical outcomes. So this is a case of a root coverage in the lower anterior tooth. It's a RT3 type of recession defect, and we have planned to do a laterally repositioned flap along with PRF to get better clinical outcomes. The use of PRF can be significant in cases where we want to increase the tissue thickness, and laterally repositioned flap is a very good technique when you have adequate amount of soft tissue on the neighboring tooth. Let's go to the video. First we'll start with giving a local infiltration with lignocaine and adrenaline on the labial and buccal side. We'll do a deepthization to create a surgical bed. Now we are doing the lateral repositioned flap. We'll give a full thickness flap incision initially and then a split thickness flap so that the flap can be repositioned without tension. We can see that we are using a 15C blade and a tissue holding forceps to relieve the flap. So we should make sure that we get adequate flap reflection and a tension-free approximation. So we use a lot of periosteal relieving for this procedure. After doing this flap reflection, we do a root planing of the recipient recession area, and we will try to reposition the flap and make sure that there is a passive adaptation onto the surgical site. So once we make sure that we have passive adaptation, we do something called as cutback incision. This makes the flap more relieved. So this is a stage where we take blood from the patient's antecubital vein. See, we draw normally 10 ml of venous blood, and once the blood is withdrawn, we transfer that to a vacutainer tube, and this is this pin at normal protocols for preparation of PRF gel. This PRF gel is adapted onto the surgical site, and we make sure that there is a proper closure of the PRF gel over the with the flap. And once this PRF is placed, we start suturing the flap. Initially, we start suturing the mesial portion of the flap using a independent sling suture. In this case, we have used a 5-0 vicryl. So we take the bite in the flap, and we make sure that the flap is approximated. We use a simple interpreter suture for approximating the lateral borders of the flap. So once this sling suturing is done, we continue with interpreted sutures to get a good flap approximation and to close the vertical incision made on the mesial aspect. Once this suturing is done, we give 1 or 2 sutures to make sure that there is a good adaptation of the flap on the mesial aspect. Once this is done, we can start doing the suturing of the distal aspect of the flap. For doing this, we use a simple interpreter suturing technique. We take a bite in the flap and we try to approximate using the unraised tissues on the distal aspect. So we place 2 or 3 interpreted sutures to make sure that there is a clear watertight suturing done. So once we finish the suturing of the flap, the next important step is stabilizing the base of the flap. This is done using a periosteal anchoring suture. So this is the step showing the suturing of the periosteum. So this is the one more interpreted suture. So now we will go on to the suturing of the base of the flap using the periosteal anchoring suture. So in this case, we have made 2 periosteal anchoring sutures, one on the distal aspect and one on the mesial aspect. So the importance of this periosteal suturing is to immobilize the flap and make sure the mobility of the lip is not being transferred onto the delicate healing area. So once the suturing is done, we give a periodontal dressing, and that's a clear suturing done. So once this is done, we do a periosteal, we give a periodontal dressing to make sure that there is healing happening without any mechanical disturbances. The patient is given routine antibiotics and painkillers to reduce post-operative infection and pain. This is the pre and post-op images You can see that there is a complete root coverage in the post-op picture. Of course, this is just a 2 weeks healing period. We are following up the patient for another 3 to 6 months to see how long-term is the stability of the results. Thank you for your valuable time. Hope this video was very informative and you can incorporate this clinical technique into your practice.